Gerie DiPiano, and you are listening or possibly watching the Love Mia Vita podcast. Today, I'm here with my co-host, Dr. Catherine Sharif, and Catherine and I are going to be having a conversation with Danica Belisle, who is a doctor of physical therapy and is an expert in pelvic physical therapy. And that's our topic today. The topic of pelvic physical therapy. What is it? Why should a woman consider it? And what are some of the different conditions that may be addressed by pelvic physical therapy? But before we jump in, since many of you may not have met Dr. Sharif in the past, the past podcast, Catherine, perhaps you could start by giving a little bit of your background, and then we'll jump in and have Danica do the same.
Okay, great. Thank you, Gerie. And Danica, so happy to have you here today. So I'm an internist in Philadelphia, and my practice is primary care in women, and we incorporate a lot of office gynecology. And we feel that women shouldn't have to have two different doctors to take care of themselves, and that physicians should know all about reproductive health. So one topic I'm very interested in is in pelvic floor physical therapy. 20 years ago, I had a wonderful mentor, a urologist by the name of Dr. Tamara Bavandam, and she taught me about the pelvic floor. And I thought the vagina is like where you put the speculum. That's where the speculum belongs, not that it is part of this very complex system. So I can't wait to hear more about what you have to say.
Thanks, Catherine. So Danica, tell us more about Dr. Danica Belisle and your journey to become a pelvic floor physical therapist.
Hi, I'm Danica Belisle. Thank you, Gerie, for having me on the podcast. I'm a physical therapist in Shorewood, Illinois. I currently run a mobile practice providing pelvic floor physical therapy for women in home, because I find a lot of women have a hard time leaving the home with little ones and not having childcare. So I'm like, it'd be a good idea for me to come to them. So I started that last year, but going backwards, I was a hospital corpsman in the Navy for 4 years. Then shortly after that, I graduated from University of Illinois in Urbana-Champaign with my bachelor's in integrative biology, then went to Midwestern University to get my master's in biomedical sciences. Then I got my DPT at Governor State. So I went to school for a long, long time. But I've been a PT for over 7 years now. I originally started doing mainly orthopedics, and a lot of my experiences as a therapist and my own personal experiences kind of led me towards pelvic health, not only from having 2 children of my own and having issues, but I felt like pelvic floor physical therapy was the missing piece when trying to resolve any dysfunction with like low back pain, hip pain, pelvic pain. I found that pelvic floor plays a dual role in lumbopelvic function. And there's been many studies showing that more than 90% of women who have low back pain will also have pelvic floor dysfunction. So they go hand in hand. But I love it. It's a very underserved area, and it's very rewarding when you can change someone's quality of life. I've come across people where they don't want to leave their home because they're afraid that someone can smell their urinary incontinence or fecal incontinence. People avoiding social events because of that. But I love it so much. And this is like the most passionate I've ever been in my career.
Well, you're a lifelong learner for sure. And I hear that because I think all of us, the 3 of us, are probably lifelong learners. I continue to educate myself on topics that sometimes are pretty inane, but most of them actually relate to what the work that we do here at Fem Pharma. And I love medicine and science. So I think we are all appreciating your journey. And thank you for sharing that with us.
Thank you.
Catherine, perhaps you want to start off with some questions that you have for Danica.
Yes, so for our listeners, I would love, who may not know much about the pelvic floor, I would love to hear the way that you conceptualize the pelvic floor. I'll give you an example. Sometimes I describe it as a bowl to my patients. Other times, I'll talk about a hub and spokes. And, the hub is the perineum and the muscles are the spokes that go in there. And so how do you describe it? Because it is abstract and complex.
It is. So I like to teach patients that the pelvic floor is almost like a trampoline holding your pelvic organs up. There's 18 muscles in the pelvic floor, and a lot of people are not aware of how many there are, and they all play different roles. But they support nerves, they innervate the reproductive, colorectal, and urinary organs. I assess like the weakness, if there's tightness, scar tissue, any sort of spastic tissues that we may find. For example, a lot of people think pelvic floor physical therapy is all about like doing Kegels. I don't like to call it Kegels. I call it like pelvic floor contractions. But it's not just that, because it's not for everyone. Like, for example, if someone came in with painful bladder syndrome, Kegels are definitely not in the picture for that. Usually they need a little bit more down training, muscle lengthening, a lot of breath work to help down train the nervous system in order for those muscles to relax and lengthen. And then if there is weakness, after we get the muscles to calm down, then we can probably initiate the Kegels. But also if I come across someone with pelvic floor weakness, they can have symptoms such as like urinary or fecal incontinence, pelvic organ prolapse, pain, discomfort, or any sort of like pressure towards the pelvis. So for those patients, if there's weakness, a pelvic floor contraction would be more appropriate. But yeah, the main focus is how the organs move upon each other is important, and how those muscles react to it, and see how they're functioning.
So it's interesting that many women, when they think about PT, physical therapy, they may be thinking about you manipulating their muscles so externally. But tell us what the baseline, how you do a baseline exam. So let's say I came in for, I had a complaint. Maybe I was having urinary incontinence. Just, we can use that as an example. What process do you go through in order to assess what I may need as a patient?
Yeah. First, be the initial evaluation. So the very beginning is just getting a lot of subjective, their health history, their symptoms, any questions that they may have, and see what their goals are. If they want to return to biking or be able to jump again. But after gathering all that information, then we do the initial assessment of checking their posture and how they sit and how the load transfer occurs. Like if they tend to lean over one side more than the other while sitting. We check movement patterns, if there's any faulty moving patterns that they're just in a habit of doing over and over, but they tend to cause pain. Range of motion to see what movements can provoke their symptoms, and it'll give me a better idea which muscles can be involved. Next would be an external assessment of the pelvis, where I check pelvic alignment, the strength of the trunk and hip, or any other body parts that may be involved. The internal assessment is, with patient's consent. So when we do internal pelvic floor assessment, We check for if there's a prolapse, any tenderness or painful areas, muscle strength, their endurance, reflexes, tone, their coordination with their breathing, and just overall function of the pelvic floor. I use the Laycock quantitative assessment scale to assess strength and endurance and the quick contractions, slow contractions.
What is the
then
Laycock scale? Can you describe what the Laycock scale is for listeners?
Yeah, so the Laycock scale, so P stands for the power, so strength. So just want to see how strong they can hold a contraction. Then endurance, I want to see how long they can hold that contraction before fatiguing out. And then the R represents repetitions. So how many times can they do that with a little bit of a break in between? And then F stands for the fast twitch. So can they contract, relax, and see how much they can do that in 10 seconds.
So
Is that all done internally?
Yes.
that was my question.
Yeah, internal for that. Yes.
Okay. Okay, so you might have, say, a finger inside the vagina and say, squeeze my finger.
Yes.
Mhm.
Yeah. So it's graded 0 being like, no palpable contraction, 5 being, absolute strongest. So what I look for is if the patient can coordinate both vaginal canal, like the walls of the vaginal canal, if they equally squeeze around the finger, if I feel a gentle tug, almost like a baby sucking on your finger,
Right.
then I would say that person had 5 out of 5 strength. Sometimes I'll feel one side of the vaginal canal has a contraction, but the other side is not, and there could be some sort of dysfunction there, whether the muscle is being inhibited because it's in a contracted state, or if it's tight, painful, or any scar tissue might be involved. So in that case, we try to, do a little bit of scar tissue mobilization and try to see if we can do some manual techniques to facilitate that muscle to coordinate properly.
Great. Can you discuss the number of women who have low back pain who may have a pelvic floor disorder? That's intriguing.
It is, yeah, because they're next door neighbors. They're all very close in proximity. And I like to look at the trunk as like a canister. If you have your diaphragm as the top, the sides of your trunk, and you have your obliques, then front, rectus abdominis, transverse abdominis, you have your back muscles, and then the pelvic floor. So they all, when they're all functioning properly, the pelvic floor is happy. So.
Sure. And then how can a clinician tell if back pain may be due to pelvic floor as opposed to lumbar strain?
It'll be hard to kind of see what came first, the chicken or the egg. And that's where I'll kind of gather their subjective, like how long they've had their back pain versus how long have their pelvic floor issues have been occurring. Because and we kind of see what is actually the driver of all these symptoms. We try to get to the root cause, and yeah.
Okay. Do you think that pelvic floor spasm or pelvic floor dysfunction could be associated with constipation?
Absolutely, yes. Well, the pelvis is a very small space technically. And so if you have the sigmoid colon sitting in there, the bladder, and there's not much room. So if we have, constipation going on, that's going to take up a lot of the room, and the muscles can't move and glide and contract, relax like they should. Organs they don't technically move, but they should be able to glide upon each other with movement. So if there is constipation blocking, pelvic floor gets angry.
Yeah. I do wonder why women have so much constipation in this country. And I think we've barely scratched the surface of diagnosing pelvic floor problems that we're waiting for. I mean, we need more education, and we need to listen to our patients, refer to someone like you, because the ones who get to you, I think, are the lucky ones, right?
I would hope so. Yeah. I feel
Yeah.
like a lot of our sessions, it's very educational. It's, I ask them how much fiber they're intaking. And to be honest, a lot of them are well under the recommended 35 grams. And
Yeah.
it is very hard to reach 35 grams of fiber daily, even for someone who is strictly on a vegan diet. So, I mean, we discuss like other food options, and I'll give them a handout of certain foods with fiber.
Mhm.
And if they still just cannot stomach 35 grams, like, hey, if you're a cereal eater, there's great cereals out there, and that can probably cut off about a third of your daily needs of fiber. Yeah, and then, teaching them too that water is your best friend, like your body is mostly made out of water.
Yeah.
And that's probably one of fiber and water. Those are the big ones for
Yes.
sure.
Women don't get enough fiber. And I know when I talk to my patients, they tell me, yeah, well, I eat salad. And I tell them lettuce, tomato, cucumber, radishes, peppers, carrots. They have water and they have vitamins. So it's like vitamin water. That's your salad. But most salads do not have things in them with high fiber, like, for example, like chickpeas. One of the things I also tell my patients is that, an apple is like 2.5 grams of fiber. So you'd need a lot of apples to get to 35 grams of fiber a day, but a pear is about 7 grams of fiber. And so there are ways to get fiber in your diet. And of course, with cereal too, you could knock off a huge amount of fiber. So it sounds like you do so much counseling in your job.
Yeah, it is. And it's pretty eye-opening. A lot of people don't know these things. I feel like pelvic health it's like forbidden to talk about. When I was going through my own pelvic floor issues after my children, and I would bring it up to some friends, they're like, oh, I'm sorry to hear that. Like, it was hard to find someone to relate to. And but yeah, the information and the help is out there, and I'm hoping to spread more awareness and for women to get the help they need.
Sound like a wonderful advocate.
Thank you.
Absolutely. I had the experience of running a clinical trial for overactive bladder. And when we were doing our inclusion and exclusion criteria, and we interviewed many of these subjects for the study, they experienced both what we will call chronic pelvic pain syndrome. They also had a combination of what we call overactive bladder and stress incontinence. So both urinary incontinence and mixed incontinence. It was very imprecise, right? It was very imprecise, and also constipation. So the interesting part of that was that for those women that had constipation, they were using laxatives more than they should have been using laxatives. So part of the problem that we encountered was we had to exclude those women because their overactive bladder, or these bladder symptoms that they were experiencing, had a lot to do with the fact that they were overusing laxatives. They really hadn't addressed the underlying cause of the bladder problem or the constipation. So they used medication and sometimes overused the medication. What are your thoughts on trying to break that down to figure out what came, you said this earlier, what came first, the chicken or the egg?
Yeah. And well, I am not a fan of laxatives. I try to talk my patients out of it because long-term use of it, your body starts to, develop a dependency on it. But I try to see if like they can do daily movement, movement to their core. And like there's also a colon massage that I teach patients, which is really easy. But usually it's a lifestyle change. It really is. And the patient has to be willing to make these little changes. And so what I like to tell them, like, if you're going to find some cereals like with fiber, make sure you like it. If you want it to be something long-term and make it become a habit, you have to enjoy it. You don't want to make yourself miserable and force yourself to eat the fiber to relieve your constipation. And sometimes like it's eye-opening for them. They're like, oh, I never really thought about it that way. Or I was telling like, when you're eating your fruit, like, eat the skin too. The skin will have some fiber, some insoluble fiber. Let me see what else. Oh, that's about it.
I'm intrigued by the comment on the laxatives, because obviously there are a number of laxatives that are on the shelf today. And there are weight loss drugs that have become available today, which effectively are, encouraging the same type of behavior. So the pelvic floor physical therapy really looks at the underlying causes. And there are so many different types of symptoms that women experience that could be ameliorated by pelvic floor physical therapy. I was actually surprised in a good way for the number of different types of conditions and the different ways in which one could address that. So maybe you could describe a few of those for us.
Yeah, for postpartum women, a big one is diastasis recti, which is ab separation. Incontinence is another, overactive bladder. Going back to incontinence, I see a lot of urge incontinence with postpartum, like immediate postpartum. Constipation is big. Hemorrhoids, anal fissures, so those kind of go with the constipation. Pelvic organ prolapse, low back pelvic pain, breastfeeding mechanics, that a lot of women will complain of upper back pain, shoulder, neck pain from breastfeeding. So I teach them, mechanics, posture, exercises to keep them more upright. Tailbone pain, coccydynia, that's what it's termed. Also episiotomy and C-section scar pain. That's also a really big one, where some moms will feel like they can't use their abs, or they're unable to have intercourse because of their episiotomy scar. So those are some of the top ones for postpartum.
It's a pretty long list.
I'm probably missing some too.
Yeah, there's a pretty long list. And, and yet when we have conversations with women, again, whether it's on the clinical side of things or it's on the consumer side of things, it's easy to want to start with medication and not look at the contributing causes of it and ways in which one could address that, again, in the most effective way without necessarily resorting to one more pill. It sounds crazy since I'm a drug manufacturer, right? But I really do believe in prevention. I look at natural ways in which to address women's health issues, symptoms that they are experiencing. And I think pelvic PT is a very important component of the equation. Certainly, pharmaceuticals and over-the-counter medications that are known to be efficacious can be helpful, but not until one has discerned what's going on.
Yes.
Can you comment about pelvic floor disorders in men, and are they common?
I actually do not treat men at the moment.
Mhm.
I am trained to treat them, but right now, since I'm doing mobile practice, I'm not doing men at the moment. But some will have like testicular pain
Mhm.
with ejaculation. Constipation is big for men as well.
Mhm.
Erectile dysfunction.
Mhm.
After a prostate removal, a lot of them will have urinary incontinence. So retraining their pelvic floor to strengthen. And sometimes fecal incontinence as well.
Mhm. Do you use any equipment in your work?
I do. We do have a biofeedback machine, which there's a intravaginal probe, and then the patient can see it on a screen, like when they contract, relax. It gives them that auditory and visual feedback. It's really good for those that have a hard time coordinating their breath with their pelvic floor. For example, if someone is the type to squat and hold their breath and come back up, so it's trying to retrain that when you inhale, pelvic floor relaxes, exhale, pelvic floor contracts. So it's hard to retrain that coordination because during pregnancy, as the baby grows, we become more of a chest breather and we're not using our diaphragm, to its full potential. And then after baby's born, we still stay in this chest breathing pattern, but it's not efficient. We're not actually taking full breaths in. So retraining how to breathe properly. It sounds silly, but it's a big component of strengthening the core. It's the most inner muscle that you can actually manipulate and train.
You have women that come in. We talk a lot about women who may experience vaginismus. So the vagina just won't open. I always say the vagina went on strike. It could go on strike for a lot of different reasons. It could be trauma, right, as you described, postpartum trauma, difficult birth. Could be sexual trauma. It could be a combination of menopause, perimenopause, and that could be playing a role. How do you help women to relax so that you can actually do your exam? And how do you help women in particular who may have one of the conditions that I just described?
Well, so for vaginismus, most women, not all, will have also anxiety. And I can get a little bit of a vibe as I'm getting their subjective history if they're nervous or uncomfortable. So, I leave it to the patient, if you want to have the internal exam, that's fine. If not, that's okay too. So it's whatever you're comfortable with. I let them kind of lead the way. But we could still treat them even without going internally. There's a lot of external pelvic and abdominal techniques. A lot of breath work, nervous system down training. So trying to activate the vagus nerve, which is responsible for relaxing, digesting. And then there's even stretches to help kind of mobilize the vulva, the musculature that crosses into the pelvic floor. There's so many different things that we can do that doesn't have to go internal, provoke their pain and make things worse. Because the last thing I want to do is provoke their pain and then they tighten up even more. So I typically will work a little further away, maybe like upper abdominals. And, as the patient tolerates, maybe in a couple sessions and they feel more relaxed, then we can proceed if they wish to.
That's great to know because we obviously hear about this quite often where women will experience the vaginal tightening, and it may be in conjunction with some trauma that they may have experienced. They're avoiding intercourse. So the thought of going to a pelvic PT where they have to have an internal exam may put them off. So it's really good to know that this is not the only way that they can be helped by pelvic physical therapy.
Absolutely. And there's things like if they don't want to try in the clinic, they can try at home. So say if they want to start like a dilator program and they don't want to do it in front of me, and that's fine. I'm like, do it at home where you feel comfortable, where you feel most relaxed and confident that, in yourself. So whether it's like taking a bath and calming down, play some music, do some yoga prior to it, and then see how, if you can maybe insert a small dilator to start and then see how it feels. And then we slowly can work up from there. But yeah, usually the patient always sets the pace and I'm just there to guide them.
That's good to know. Do you ever work with a psychologist or a licensed clinical social worker that can help to facilitate some of this?
No, but I don't know anyone personally, but I will refer the patient to go see maybe if there's a counselor, like a sex therapist. Most of the sex therapists here live further north. I don't know of anyone new around the area, but yeah, I would suggest like other options that they could explore just so they can make an informed decision about their health care. But yeah, counseling is a big portion of it, especially if they're experiencing anxiety with the vaginismus. or any sexual trauma in the past.
And what are your thoughts on, we see a number of different companies that have emerged, and I'm not going to single them out, but they have various devices that they claim will strengthen the pelvic floor. They're used for vaginal, they call it for vaginal laxity, and for, because that's the technical term, women may know this as it feels loose. The vagina feels, or in the case of we talk about vaginismus or vaginal stenosis, that it feels tight, and tight isn't necessarily a good thing, because that might mean that the vagina is closing on itself.
Mm-hmm.
What are your thoughts on these, on the companies that have come up with these devices that supposedly strengthen the pelvic floor?
I mean, maybe I don't know too much about them, but I think, I mean, it would be great. Maybe it's like training wheels to get you started, but I think for long-term effects, your body's going to have to do it. So, I mean, maybe it can get you started and you get an idea, okay, I can do a pelvic floor contraction, but overall, I don't know too much about them. But I think everything that a pelvic floor therapist do, like, we can replicate a lot of the same stuff.
One of the things I've observed about medical practice, conventional Western medical practice, is that we are disease-based. So we wait till you have a problem, and then we come up with a pill or something, and we aim the gun, or we aim the pill or whatever, and take care of the problem. What can we do to promote pelvic floor health so that we don't get problems?
I think immediate postpartum, or even before baby comes, like just to have more pelvic floor therapists, even on the acute floor, like labor and delivery, just, educating the patient, like what they can expect.
Mm-hmm.
Or even just like tying in pelvic floor dysfunction into a baby class, or I just feel like it needs to be out there. More women, there's just so much knowledge that I've learned over the years, and I'm like, whoa, I never knew this until my late 30s. I wish I knew this before, but there's a lot of information out there. I feel like there should be, some sort of push where there's more therapists on labor and delivery, especially because a lot of women go home and they're just left there with baby, and they're like, well, all these things are happening and no one talked about it beforehand. And
Right,
like
they can't sit down because of the coccydynia, right? They can't, they pee on themselves because of the urge incontinence. And right,
and especially like their episiotomy scar, their C-section scar, like things that they can do to help mobilize it and make it feel more comfortable as they move, have intercourse. So there's a lot that can be done.
It's interesting that you talk about the transitions throughout a woman's life. We think about it as when a woman begins to menstruate. So when she enters puberty, are there things that she should be taught as she goes through puberty about her breathing, about the way in which she conducts herself from the standpoint of her posture, the way in which she exercises and breathes? It sounds like it could all go back to developing pelvic health, even in her teens, and then moving into her 20s and 30s. I think that your, acknowledgement of what happens during pregnancy and then postpartum is super important. And then obviously when women start to enter menopause, and we know that the incidence and prevalence of these types of conditions, whether it's incontinence, fecal incontinence, or urinary incontinence, or chronic pelvic pain associated with hormonal changes, can also be disheartening to a woman, and she feels that she has no resources. So starting early, does that make sense to you?
Oh, for sure. I think when I got my first period, I'm like, whoa, what's going on? And my mom's like, here's a pad. And that was it. But yeah, I think early education is huge, because knowledge is power. And that makes women feel more empowered with their health and decisions that they make about whether they want to go on birth control or have a hysterectomy later in life or anything like that. But I feel like there's a lot of knowledge that needs to be shared for sure. And I think the earlier, the better.
So it sounds like pelvic floor PT is something that we should all embrace, and the sooner the better.
Yes, definitely.
And for those women that are uncomfortable, because let's face it, there are, a number of women that are uncomfortable, even with a women, women practitioners are leading medicine these days, right? And more gynecologists are women, more nurse practitioners are women. They're dominating the field. What about the field of pelvic PT? Is it mostly women who are practicing?
Yes, mostly women. I know only one male therapist, but otherwise, yeah, everyone that I've come across are females.
Which also speaks to the incidence and prevalence of these types of problems in the male
Yes,
population, right? So
yes.
it does make sense. And in terms of training, so if you are seeking help from someone who is a pelvic PT, what should you look for? I mean, there are certainly women that are in your region should reach for you at Midwest Pelvic Health. But what if they live on the East Coast, or what if they live in different parts of the country and they're looking for someone who is a trained pelvic PT? Are there certain credentials that they should be looking for?
You can go on Herman and Wallace. That's where I did all my training. They're the large pelvic institute. On their website, they have so anyone that's did training through them, they can practitioners can put themselves into the directory, and you can type in your zip code and see who's available in your area, as well as APTA, which is the American Physical Therapy Association. Those are two big ones that you can check to see if any pelvic floor therapists are near your area.
Excellent. Thank you for sharing that with us. So it's not just anyone that can do this sort of work. I believe what you've learned or as a listener is that, yes, there are physical therapists, and then there are pelvic physical therapists. And the training for the pelvic physical therapist is more intensely focused on it may start out more generically as a physical therapist, but there are special credentials that pelvic PTs earn that help them to distinguish themselves from others and to provide that as a resource to you, the patient.
What are the credentials?
So if you have taken the training through Herman and Wallace, which is one of the major training groups in the country, that certainly is a credential that you should be looking for.
Yeah, and that's where you can find them on their website. There is a PRPC certification, pelvic rehab practitioner certification. Yeah, there's some people with that. I haven't sat down for the exam, not yet. Hopefully, maybe end of the year. But that's something, yeah, patients can look for that. And then if they were certified through APTA, it would be WCS, which is the women's certification. So those are the two that they can look for.
Excellent. Well, thank you for that. We have really enjoyed having this conversation. I don't know about you, Catherine.
I've learned so much.
This is a great conversation. I truly hope that our listeners and viewers have done the same. The takeaway is that you do have resources available to you. If you are experiencing any number of these symptoms, perhaps a pelvic physical therapist is a person to whom you should reach out. If you happen to be in the Midwest, you can certainly reach out to Danica, visit her website, Midwest Pelvic Health. If you purchase one of the Mia Vita products, the personal lubricant and vaginal moisturizer, you will get a discount. Just put in the code MWPH10 and you will receive 10% off. And obviously, if you are experiencing pain, burning, itching, you should probably consider using something. We have a water-based personal lubricant and vaginal moisturizer that we see women using quite often. And you said something earlier about compliance, right? So if you really hate the whether it's the cereal, or if you really hate eating fruit, you're not going to do it. And so what we try to do with our product line is to make it easy to use, very straightforward, elegant, highly effective ingredients. Just need a tiny little amount, but you need to try it and to experience the difference. So you'll have that opportunity at a discount. So we are very grateful to you, Danica.
Thank you for having me.
Catherine, as my co-host. This is a wonderful conversation, and we want to encourage our listeners to check out Midwest Pelvic Health. Danica Belisle, thank you so much for your time today.
Thank you so much.
Gerie.
We look forward to the next time.
Thank you.
Till then, this is Gerie DiPiano and Dr. Catherine Sharif signing off. And remember to love Mia Vita.